Good morning. Can you see my screen?
Yes, we can see your screen, Doc. Thank you so much. Good morning, everyone, and welcome to this case presentations by Dr. Murinye. Let me just make a brief introduction and say, since we started the program of subspecialization rotation for our junior registrars, we endeavor to make sure that they get the principles of subspecialist practice. They also get the application of subspecialist services in the obstetric services. So Dr. Murinye's case presentations are part of her exit from her attachment. We use this case presentation to also assess whether our junior registrars have acquired the foundational knowledge or the principles of fetal medicine, and also to see if their clinical reasoning has been improved during their attachment to us. So please participate, ask them questions, quiz them, test their knowledge. Do not pity them because you won't be doing a favor. Challenge them so that you can stimulate them to think through so that they become better specialists. So yeah, so Dr. Murinye, you may go ahead. So be free to comment and be free to criticize your work, please. Don't give a free pass. That's all I can say. Thank you. Please go ahead, Doc.
Okay. Morning, everyone. Apologies, I have a flu. So my voice may be a bit faint at times. I'm going to present two cases that I came across during my attachment to the fetal medicine unit. My first case is a case of holoprosencephaly, and we know that holoprosencephaly is a developmental defect which occurs during development of the embryonic forebrain. It is commonly associated with mid-facial defect. It is a result of incomplete development of our central nervous system structures. And there are three classic types which are described, and these include alobar, semilobar, as well as lobar holoprosencephaly. However, there's also a newly described interhemispheric variant. In terms of embryological development, we know that holoprosencephaly is a result of incomplete development and separation of the midline central nervous system structures. We know that our central nervous system is derived from the neural plate, which initially is a disc-like structure that then invaginates to form the neural tube in the third week of life. We know that the neural crest cells will also migrate and they will organize themselves around the neural tube, eventually moving towards their predetermined destination. The neural tube will then undergo cranial caudal folding, resulting in rostral and caudal neural pores. And complete closure of these rostral and caudal neural pores will then lead to the central nervous system, to the normal central nervous system development. However, we know that closure of these rostral and caudal neural pores may actually occur, and this will result in a range of manifestations ranging from anencephaly as well as our neural tube defects, the myelomeningocele cells as well. The primordial brain develops into two hemispheres, and disturbance of the development of these two hemispheres will then lead to the development of holoprosencephaly. And this affects 1 in 15,000 to 16,000 births. In terms of the etiology of these malformations, we know that it's heterogeneous. There's a significant genetic component which is noted, and this involves different genes like the sonic hedgehog, like the zinc finger protein of the cerebellum, the sign oculis for newborns, Drosophila, as well as the transforming growth factor beta-induced factor. However, when we come across these cases, we also undergo aneuploidy screening. Although in most cases you'll find that there may not be a particular chromosomal anomaly noted, it has also, holoprosencephaly has also been noted to be associated with trisomy, particularly trisomy 13 and 18. Environmental factors are also a significant consideration. You'll see that in terms of the literature review that we did, in some of the cases it was associated with maternal diabetes being noted to increase the risk of these defects up to 20 times. The administration of retinoic acid to these mothers preconceptionally, as well as in the early conception period, is actually been noted to also be an etiological factor in terms of these CNS maldevelopments. Drug and alcohol abuse during early pregnancy has also been noted. Hence, this serves to portray the fact that preconception counseling is essential to ensure that if our patients are diabetic, they are adequately controlled to help to protect against developing these anomalies. And also for patients who had retinoic acid prescribed maybe for severe acne, it is also important for us to highlight this risk to them as well. And modifiable factors such as the use of drugs and alcohol also need to be addressed in terms of our preconception visits. And of note for these patients, it is also essential to remember that where we have identified all these possible risk factors during the preconception period, it is essential to start our patients on folate to try and help protect against some of these central nervous system anomalies. In terms of the different forms, we described that there are four main types which are described. We have our very mild holoprosencephaly, which is characterized by a relatively normal appearance in terms of the face. However, they may also present with microcephaly, a narrow nasal bridge, and a single central upper incisor. In terms of assessing the severity of holoprosencephaly, we look at the facial deformities, we look at whether there are any feeding or visual or hearing impairments. We also look at the intellectual effects as well as the mortality. And you'll find that for very mild holoprosencephaly, the degree of impairment of their feeding, vision, and hearing actually depends on the degree of facial involvement. In terms of their intellectual progression, with mild holoprosencephaly, we expect that there is relatively minimal CNS involvement. And in terms of their development, milestone development, we only expect minor developmental delays. Hence, it's mostly as a subclinical effect, and we don't expect any issues in terms of mortality and minimal morbidity. The second variant, which may also be classified as mild holoprosencephaly, is characterized by a relatively normal facial appearance. However, you may find that the eyes will be close together, leading to closely spaced eyes, as well as a depressed or narrow nasal bridge. In terms of their feeding, vision, and hearing, this actually depends on the degree of facial involvement, and they also manifest with a range of developmental delays. However, long-term survival is possible in these patients. Hence, it is important to counsel affected families so that they know what to expect in terms of their developmental delays as well. Lobar holoprosencephaly as well as semi-lobar holoprosencephaly can be listed under moderate to severe holoprosencephaly. They have a wide range of facial deformities, with some of them actually having a normal spacing between their eyes. However, for some, they will be close together. They may also present with a depressed nasal bridge, bilateral cleft lip with a medial process present. The impairment in terms of their feeding, vision, and hearing actually depends on the degree of facial involvement. And they also manifest with a range of developmental delays as well as intellectual deficits. Mortality for this group is around 50%. And however, when they only have isolated lobar holoprosencephaly, they may actually survive beyond 12 months of age. And this is also illustrated in one of the case reports that I came across, which we will discuss shortly. In terms of Alobar holoprosencephaly, this is actually the most severe. In terms of the facial defects, there's a wide range. Some may present with cyclopia, which is a single eye, a single orbit. Some may actually present with proboscis, which is like a development which is noted above the eye. And then some may actually present with cyclopia without the proboscis, which is the single eye, but without the development, without the protruding growth above the eye. They may present with severe hypotelorism with separate orbits, however, with the proboscis, which is actually in between the eyes. And they may also present with a single nostril nose. With Alobar holoprosencephaly, there may also be absence of the premaxilla with a median cleft lip. As we stated before, they may have ocular hypotelorism, which is their eyes which are set close together. They may also have anophthalmia or microphthalmia. And also as part of the spectrum, they may actually have a relatively normal facial appearance. Their feeding and vision and hearing will depend on the degree of facial involvement, and they may also manifest with a range of developmental delays as well as intellectual deficits. And the most severe CMS deficits are actually noted in this type. And in terms of mortality, they really survive beyond the first week of life. And for those who survive, 50% will actually die between 4 to 5 months of age, whilst only 20% survive beyond the first year of life. And this is highly dependent upon the amount of support that the family that they are able to receive in terms of feeding, as well as a general care. So this is just an illustration of the possible clinical features. For example, we talked about them having the proboscis. We talked about hypotelorism, which is a decreased distance between the eyes. We also talked about how they may present with a cleft lip as well as a cleft palate, and a cyphocephaly, which is one nostril. In terms of our case presentation, we saw a patient who was a 28-year-old who was in her third pregnancy with one child at home. She had a history of an early neonatal death in her second pregnancy. And this baby was, and at delivery, they actually noted that there was microcephaly of this second child. She presented in fetal maternal unit at 12 weeks gestation. She had been cancelled that she needed to book early and that she needed to have assessment done as early as possible in her next pregnancy. On examination on ultrasound, we noted that there was an abnormal appearance in terms of we noted an abnormal appearance in terms of the fetal brain. However, we weren't quite sure what exactly was happening, but we went on to order aneuploidy screening in view of the fact that she had had microcephaly in her previous pregnancy. And we were also not quite sure what was going on in terms of the image that we had found. We then booked her for assessment in the fetal anomaly clinic, and she later presented, she was now at 15 weeks gestation. She came in with her result for aneuploidy screening, which had actually come back as high risk. So this is a simple illustration of the image that we got at her first ultrasound, with our image being this one. And the figure on the right is a comparison on what we'd expect in terms of first trimester CNS imaging, whereby you're supposed to see the midline. You're also supposed to see the choroid plexus with the butterfly appearance, as you can see illustrated in this research cake figure. However, when you look at our diagram, you see that you can't really see the midline, and posteriorly, you can only see a single ventricle. So this is what we saw initially when we went on to order the aneuploidy screen. This is now a representation of the image that was taken when she then presented at 15 weeks in the fetal anomaly clinic. And you can actually see that there is a single ventricle, this one illustrated here. You can also see the choroid plexus. And as you can see, we don't have that butterfly appearance that we expect. And centrally, there's fusion of the thalami, which you can actually see here. And this is all evidence of which was supportive of the diagnosis of holoprosencephaly. In terms of what we would have also expected, we would have looked for microcephaly. And when we examined our patient, there was no evidence of microcephaly. The measurement in terms of the head circumference was at the 30th center. We also went on to examine for microphthalmia, ocular hypotelorism, as well as ocular hypotelorism. And this is the illustration of her images. And this illustrates both orbits. And as you can see, the interorbital distance can actually fit one orbit. So there was no evidence of hypotelorism. However, it did appear as if there was a protrusion of the of her orbits, and we concluded that there was a protrusion of the orbit in this case. I'm sorry that this figure is a bit blurred, but this actually shows the facial profile. And as you can see, starting from here, which is the cranium, this actually appears to be quite flat in terms of the facial profile. We could not actually identify our nasal bone in this place at this time. So we concluded that she had a flat facial profile. We concluded that she had a flat facial profile with arrhynia. There was proptosis. There was also a monoventricle as well as a cleft lip. And based on the facial defects that we had identified, we anticipated that there would be severe mental handicap in this patient, and they were unlikely to survive for long without active management. In terms of getting a diagnosis for this patient, we went on to offer them amniocentesis. As you will recall, this is a couple that had actually had a microcephalic baby in their second pregnancy, which had actually also resulted in early neonatal death. And in terms of moving forward, as well as for closure, we thought that amniocentesis would help in terms of seeing if we can actually get a definitive diagnosis, which would also inform further management. In terms of the literature review, we came across a variety of articles which looked at the different variants of holoprosencephaly. And this is a study by Paul Enaru et al., which detailed 2 case reports of holoprosencephaly that they came across. And this case report was published in January of 2012. And in terms of their cases, their first case was actually a patient who was diagnosed at 29 weeks gestation and went on to deliver at 32 weeks. In terms of mortality, this baby died soon after delivery, and there were actually no significant risk factors which were picked up. She was a 26-year-old who had had a relatively uncomplicated pregnancy, whose first pregnancy had also been uncomplicated, and her child had a normal neurological development. And the second case they also described went on to also deliver prematurely at around 29 weeks. However, in these fetus, they noted microcephaly. They also noted, and they were actually able to go on and conduct an autopsy on this patient. And their autopsy revealed local holoprosencephaly, pneumocystinosis, And there was midline fusion of the cingulate gyrus, and as well as an arachnoid cyst was also noted. In terms of semilobar holoprosencephaly, this is a case report which was described by Esa et al. And this case report was describing a patient with semilobar holoprosencephaly. And this diagnosis was made after the woman actually presented with severe preeclampsia at 29 weeks gestation. They noted the semilobar holoprosencephaly at ultrasound. And because of the severe preeclampsia, they needed to deliver the patient, and they went on to induce labor at 29 weeks. And they delivered a male fetus with two separate eyes. However, they were closely set together, which is hypotelorism. They also noted that with semilobar holoprosencephaly, these fetus had a single patent nostril, and they also had other associated hand anomalies such as polydactyly, as well as agenesis of one of their fingers. And in the last case report that I came across, it was describing a case of lobar holoprosencephaly. And this was a pregnant woman who was found to have a fetus with lobar holoprosencephaly. And she had been referred to their center because they were suspecting that there was corpus callosum agenesis. However, they noted that there are significant difficulties which may be encountered in terms of making this diagnosis. However, they went on to illustrate that there was fusion of the anterior horns, as well as fusion of the fetal brain anteriorly. Unfortunately, I was not able to get access in terms of finding out what was the outcome in this particular case of lobar holoprosencephaly, which we know is one of in terms of the severity, it's one of the less severe, although we know that the variant is actually the least severe. The last case report was by Garwish et al., and it actually describes a fetus who was diagnosed with lobar holoprosencephaly, and they went on to do a 9-month follow-up in this case, illustrating that some of them do survive the early neonatal periods, and up to 20% can actually survive for more than 12 months. And so in terms of the learning points for us in this case, the first one was aneuploidy screening. This is a patient we should not have offered aneuploidy screening at all because she actually had obvious abnormalities on ultrasound scan. But as was highlighted when we actually discussed this case during the fetal anomaly clinic, we cannot diagnose what we don't know. So exposure is essential in the fetal maternal unit for you to be able to identify anomalies and manage them appropriately. This case also highlighted to us how much it is essential to counsel patients on the prognosis. And this was further illustrated by another case that we were following up, where the woman was where we actually noted that the fetus had semi-lobar holoprosencephaly, and the mother went on to deliver this last weekend. And in terms of the development, there are no facial deformities for this fetus. However, one point of debate or one point of contention was with the midwives who were wondering, who were asking whether we had overdiagnosed. But as we have illustrated in this presentation, there can be various facial presentations, but that does not if we have a normal facial profile does not actually cancel out the fact that this baby has semi-lobar holoprosencephaly and will need regular follow-up because, as we have said before, it's a spectrum which can have the facial abnormalities, but it can also but in other milder cases, it may actually only present with intellectual or developmental delays. Hence, there is need for monitoring for this fetus that was described. And we hope that for this baby that was subsequently delivered, and we hope to come back in a few months with the report in terms of that baby's progress. And yes, that is my last point, which illustrates the need for long-term follow-up, as mild forms may present with delayed milestones as well as mental handicap. That is the end of my first case.
Thank you so much, Dr. Murinye. Without wasting time, so that you have time to present the second case, let me go to the chat box for some questions for you. The first one is, what is the difference between Alobar holoprosencephaly and hydranencephaly? That's number one. Then the second one is, we are being thanked for this wonderful presentation. But the question is, are there any extra partial or extra cranial abnormalities or soft maggots to look out for on ultrasound? Those questions are directed to you, Doc.
Okay. Okay. Thank you, Dr. Viringa. I think for the first question, they asked what is the difference between
Hydra holoprosencephaly.
Okay, so with hydranencephaly, you actually find that the cerebral hemispheres will be absent. Because with holoprosencephaly, we actually have our cerebral hemispheres, but we are saying that they are fused. There's no separation. You can't separate the different hemispheres. And with hydranencephaly, they're actually absent. So I think that is the fundamental difference. I don't know, maybe if there's a better explanation.
I think that's excellent. That's excellent. Then the second one, remember the other one is a division problem. The other one is more like a vascular thrombosis problem where the internal carotid artery thromboses and liquefies the cerebral hemispheres. So yeah, but your description is correct. That's what you see on ultrasound. Then the second one, any extra cranial features, and what is the benefit of looking for them anyway?
In terms of the cranial features, apart from the CNS features that we talked about, like the monoventricle, the fusion of the thalami, we know that when you look at your orbits, they may present with hypotelorism, or they may actually present with
extra fascia and extra cranial, any besides the extra cranial, any other features? Since you have already mentioned the extra cranial, the fascial deformities, or what is the benefit of looking for more, in other words?
a small micrognathia.
So what is the benefit of looking for more, Dr. Murinye? What would be the clinical, I think you've dropped out, maybe you can try to come back, but what is the benefit for looking for more? Carla is saying for counseling purposes. It's beyond counseling. Yes, counseling is very important, but what is the benefit? Why do we have to check for more? So I think so that we can move on to the next case, we should always remember that holoprosencephaly can come as an isolated finding, number one. Number two, it can come as an associated finding, associated with either trisomy 13 or 18, but the most common is trisomy 13 of the two. Or it can come as part of a genetic syndrome. So looking for other defects will allow you to triage and say, is this holoprosencephaly likely associated chromosome abnormalities or genetic syndrome? What is the benefit, Dr. Murinye, of knowing this information? Of knowing, is it an isolated holoprosencephaly case, or is it associated with chromosome abnormalities, which in this case would be trisomy 13 or 18, or is it associated with genetic syndrome? What is the benefit?
So the benefit is essentially in terms of us assessing the severity, as well as for us to be able to counsel our patients on prognosis, as well as for us to identify which other disciplines we might want to involve in terms of multidisciplinary management. And it is also essential in terms of for the patient when they are planning their future pregnancies as well, to understand whether this is actually a chromosomal anomaly, which may actually occur again, or whether this is actually a result of environmental factors. As highlighted before, this may actually be secondary to diabetes or the use of retinoic acid. So it also helps us to identify any modifiable factors that they can control for in future pregnancies and optimize their next pregnancy.
So what is the recurrence risk for chromosome abnormalities for babies trisomy 13 and 18? What would be the recurrence risk?
Huh. That's a good question to tell you. I would like a chance to look it up.
I think that is the most important underlying issue once you pick up most for Alobar, because the Alobar, whether there is association or not, the outcome is bad. But obviously, any couple would want to know, is it likely to come back again? If it is isolated, the recurrence risk about 6 to 10%. If there is just chromosome abnormality, trisomy 13 or 18, then we are talking of 1% recurrence risk. Then if it is part of a genetic syndrome, unfortunately, the recurrence could be as high as 25 to 50%, depending on the Mendelian pattern of the couple, whether they are homozygous or heterozygous. So yeah, so that is very important. What was the result of the screening test? You didn't mention the screening. This woman was offered a combined test. What was the result?
She was noted to be high risk.
For what?
Uh, I think I'll have to go back and look back at the results to tell you.
Yeah, it's important to know this. I think the lady was high risk for everything, right? She was high risk for trials 21, 18, and 13 when the woman was referred to us. So remember, it's very important. Of course, if you come across holoprosencephaly like Dr. Murinye has mentioned, we do not offer screening because the risk of chromosome abnormalities in a holoprosencephaly case is 1 in 3. So if the risk is 1 in 3, actually it's 1 in 2, because 50% of babies with holoprosencephaly, holoprosencephaly are likely to have trisomy 13. So the risk is too high, it's 1 in 2. So the woman may be cancelled towards doing a diagnostic test so that we can cancel on the recurrence risk. The diagnostic test, which is in amnio here, is not to diagnose holoprosencephaly, no. The diagnosis so that we can look for the underlying cause to say, do we have trisomy 13 or 18? Because it does help in cancelling on recurrence risk. But the diagnosis of holoprosencephaly doesn't need an invasive procedure. So the invasive procedure is there to help us in the counseling of the patient. Otherwise, very interesting case you presented. Thank you so much for taking time to work on this case, Dr. Murinye. I think without wasting much time, I don't see any questions in the chat box there. So I ask you to move on to your next case. So try to present your next case in the next 15 minutes so that people can ask you questions at the end.
Okay, thank you, Dr. Virenk. So my second case is one of tubular pregnancy. And we know that in terms of ectopic pregnancies, tubular pregnancy accounts for 94% of all these cases. However, almost 80% of these cases will actually rupture early due to a thin fallopian tube wall. And typically with an ectopic pregnancy, our patient will present with amenorrhea, bleeding, as well as abdominal pain. Our case involves a 26-year-old who was in her first pregnancy. She had primary infertility for 3 years and had only fallen pregnant in the 4th year of marriage. She was referred for suspected extrauterine pregnancy and stated that her last normal menstrual period was sometime in October of 2023. She had confirmed that she was pregnant using a urine pregnancy test, and she had subsequently booked a pregnancy around 12 weeks in Mazoe. However, no ultrasound scan was done at that time. She presented to a local clinic in Waterfalls in June of this year, where they went on to do an examination and they noted the discrepancy in terms of her uterine size compared to her date. They ordered an ultrasound scan, which was done at a local center in town. However, the sonographer did not cancel her on the ultrasound findings. She says that the envelope was handed to her and she was told to present it to the local clinic where they had seen her. She only went for review to the local clinic 2 weeks after this ultrasound scan was done. And on reviewing it, they referred her to Salim Gabi Central Hospital. On arrival, she was seen by a casualty officer who noted the ultrasound findings of an ectopic fetus with signs suggestive of demise, which had occurred some time back. They referred her to our unit for a confirmatory scan. So this is the ultrasound that we took on arrival. We can note the uterus, which we labeled here. I'm sorry, my figures are not very clear, but this is the uterus that we can see outlined here. And as you can see, there's no, the uterus is basically empty. There's no gestational sac. There's no evidence of an intrauterine pregnancy, although there was evidence of a slightly thickened endometrium. And this is the bladder, and this is the cervix. As you can see above the uterus here, there appears to be this homogeneous structure, which we went on to image. So this is the structure that we imaged, which was homogeneous in equitexture. And lateral to that, on the left side, we made an outline of what we thought could be the fetal, could be the cranium, which is white due to ossification. However, no other structures were quite visible. So we made the impression of an extrauterine pregnancy, and we then referred it to gynecology, where she was taken into theater. And these were the intraoperative findings. We can see this is the left ovary, which is attached to this structure, which is the extrauterine pregnancy. And medially, you can also see this structure, which is connected to the uterus. I think you can see more clearly on this image. You can see the uterus there. You can also see uterine tube, and you can see the extrauterine pregnancy and this brownish structure here, which is actually the placenta. And this is an image, a post-left self-injectomy, which illustrates the uterus, the right ovary, and fallopian tube. Of note, if you look at this right fallopian tube, it actually appears to be quite thick. And you can see on the other side, left self-injectomy had already been done, but you can see the left ovary, which actually appears to be quite normal. We went on to do a literature search after coming through this case, and we came across a case which was reported by Jiaping et al., which talked about how they came across a woman with advanced tubal pregnancy at 34 weeks gestation. And of note, this woman had developed eclampsia as well as HELLP syndrome. And so what this case basically illustrated was that advanced tubular pregnancy is uncommon. However, whenever we are told to evaluate a patient with an extrauterine pregnancy, and we identified the homogeneous structure that was well circumscribed that we showed earlier on the image, it may be prudent to suspect that it could be tubular pregnancy, because you find that for tubular pregnancies, because the placenta is enclosed in the fallopian tube, it actually comes out as well demarcated and crescent shaped. And this is actually valuable in terms of making an accurate diagnosis. It is also important to note that because of the poor vascular supply, these pregnancies, when they present in an advanced form, there is a high likelihood of developing preeclampsia, as illustrated in the case report. And overall, tubular pregnancies tend to have poor fetal maternal outcomes secondary to abnormal artery remodeling, venous dysplasia, as well as placental infraction. That is my second case. Don't know if there are any questions.
Hello, Dr. Murinye.
Oh, yes, I can hear you, Dr. Reding.
Great, thank you so much. Very interesting some case there. We want to open the room for questions. Any questions you want to ask on the presentation or to ask Dr. Murinye in particular, even questions on the first case, just in case you didn't have the opportunity to ask, you're more than welcome to ask. So Dr. Murinye, your presentation will not be put online because there are patient identifiers there on your images, so it will be removed. The either will see if they can delete them on the video or what. That's what Dr. Madembo is highlighting, that some of your image didn't crop out patient identifiers. It's very important exercise to do so that we keep the privacy of the clients.
Apologies
Yeah,
for that. Let me try and modify it.
yeah. All right. Great. So, Dr. Murinye, just one more question for you to say, do you think all women should be offered routine aneuploid screening at 11 to 13 weeks plus 6 days?
Yes, I do. I think every woman should be offered a nuclear screening. Although we know that there's increased risk with increasing maternal age, gradually we've been noting that even younger women are presenting with children with chromosomal abnormalities, particularly trisomy 21, which is Down syndrome. And we know that based on the severity and based on the fact that some of these diagnoses are life-changing in terms of the woman's life, as well as the significant burden it will be on the family. I do think that it is prudent to offer every woman aneuploidy screening so that decisions can be made early, and in cases where termination may be offered, it would be easier to do it earlier on before the maternal connection, before the maternal fetal bond is
Okay.
significantly developed to actually affect her even more.
Thank you so much. I think that's a correct thing. So why do you think the first at first appointment the team they was not sure of what they were looking at? Because holoprosencephaly is a first trimester diagnosis. Do you agree with that statement?
Yes, I do. I do agree it's a first trimester diagnosis.
So why do you think the team was not sure?
I think, like you highlighted, Dr. Meringa, during the anomaly screen, during the anomaly clinic, you cannot identify what you don't know. So I think exposure is key for you to be able to know the normal anatomy, and from then you can always work back and identify when it's abnormal.
Okay, thank you so much. It's called pattern recognition, that in ultrasound, you need to have seen something to recognize it. So how do you improve your pattern recognition skills? By attending more and more ultrasound scan sessions where defects are scanned, so that when you see something next time, you say, oh, I've seen it. So pattern recognition is a skill that can be developed through rigorous exposure of yourself to abnormalities, so that you can recognize them when you see them next time. Okay, thank you so much, Dr. Murinye. Well done. I don't see any questions in the chat box or any hand raised. I think we want to call this meeting to a closure. Thank you for taking time to attend. Our next meeting will be 2 weeks from now. Next week, or are not having a meeting, we'll have it the week after. Otherwise, enjoy the rest of your Friday and the weekend to come. Bye-bye.
Thank you.